Thank you, Roger. Thank you, Linda, and thank you, ASBMR, for holding this very interesting meeting. My subject today is the effects of vitamin D in muscle and relationship to bone. I'm trying to advance the slide. Oh, there we go. The conceptual framework that ties vitamin D to muscle and bone is illustrated here. On the left-hand axis, we see the link between vitamin D insufficiency and increased risk of fractures through its effect in calcium absorption, parathyroid hormone, bone turnover, and bone loss. On the right-hand axis, we have links between vitamin D insufficiency, lower muscle mass, reduced muscle strength, increased risk of falling, and increased risk of fractures. I'm going to start with some comments supporting the right-hand axis here, and then turn to the left-hand, the more familiar to our bone community, left-hand axis. As you know, vitamin D levels decline substantially with aging. This is not apparently occurring because of decreased absorption of vitamin D in the elderly. This experiment compared in healthy young and older men in the wintertime the vitamin D and 25-hydroxy-D responses to standardized vitamin D dosing. And you see that the young and old had the same responses. It is a function, however, of decreased skin synthesis of vitamin D in the elderly, as illustrated in this elegant experiment done years ago by McLaughlin. The elders also tend to have less effective sun exposure, so it's that aspect that results in their poorer vitamin D status. Now, the sense that vitamin D had something to do with muscle goes way back into, I've given a couple of examples here. In 1979, there was a 1-alpha-hydroxy-D intervention in a small group, uncontrolled experiment, but with muscle biopsies done before and at the end of several months of treatment with this active D compound, showing an increase in the type 2A muscle fibers. Sato then did a vitamin D intervention study many years later, in 2005, in the stroke survivors, and found in muscle biopsies done before and after an increase in the diameter and number of type 2 muscle fibers. Now, this doesn't tell us much about the mechanisms by which vitamin D is operating. There's evidence for both direct and indirect effects of D on muscle tissue. This summarizes just some of the evidence or the categories of evidence for a direct effect. That is, an effect mediated through the vitamin D receptors in muscle. Vitamin D receptor knockout mice have muscle atrophy. Heritable vitamin D resistance patients, those with abnormalities in the vitamin D receptor, have myopathy. In adults with profound D deficiency, muscle biopsies will show profound atrophy of the type 2 muscle fibers. This has been seen repeatedly. Treatment with 1,25-dihydroxy-D has been noted to cause translocation of nuclear vitamin D receptors to the plasma membrane. And finally, and very recently, an extremely elegant experiments available online showing that vitamin D is expressed in the C2-C12 mouse myoblasts, and it's expressed in regenerating mouse skeletal muscle. A figure from that latter paper is shown here, where 1,25-hydroxy-D treatment, treatment with 25-hydroxy-D, increases vitamin D receptor mRNA expression in these myoblasts. Note the bar on the right, in which the treatment also with the 25D as well as 125 causes this. This suggests the presence of 1-alpha hydroxylase production in the myocyte. It's the first time I've seen this. This is very exciting finding. We know that vitamin D receptors in human muscle are fewer in elders than in younger individuals. And finally, I'd like to draw your attention to poster number 36 here by Dr. Lisa Seglia and colleagues. It's a pilot study in 14 frail elderly women who were treated either with placebo or 4,000 units of vitamin D. They had paired muscle biopsies, and the proportion of vitamin D receptor positive nuclei was assessed by immunofluorescent methods. And Dr. Seglia identified a 29.8% increase in the proportion of receptors that were positive compared with a small and different increase in the placebo group. You can see that poster for more detail with regard to the fiber types and relationship to change in 25-hydroxy-D. There's also evidence for indirect effects of vitamin D on muscle. We note that vitamin D receptors are not consistently identified in muscle tissue. The most famous example of this is the publication by Wang and DeLuca, in which they did not identify and are sure there are no vitamin D receptors in muscle tissue. Not all patients with very low D levels actually have myopathy. Zhu and Jim Fleet's lab identified that, has reported that knockout of intestinal vitamin D receptors in mice actually results in muscle changes. We know that high parathyroid hormone levels can lead to myopathy and poor contractility, and high-dose calcium can reverse the clinical signs of osteomalacia in some patients. So we have evidence for direct and indirect effects of vitamin D. I want to turn now to some of the clinical studies that link vitamin D to muscle performance and balance. This starting with an observational study, the NHANES in men and women actually aged 60 and older. You will see that as their 25-hydroxy-D levels go up from left to right along the x-axis, that the walking time and the sit-to-stand time declines. It declines very rapidly as levels approach the lower end of the reference range and then declines more slowly thereafter. In another such observational study out of Holland, Wickerts has illustrated that the 25-hydroxy-D level is related to performance in a group of elderly men and women. In the Health ABC study, Houston examined associations between 25-hydroxy-D levels and SPPB test times, and divided the group into roughly tertiles, but actually with boundaries of levels under 20 nanograms per mil, 20 to 30, and then 30 and higher. And overall, there was about a 1 unit better SPPB test score in the higher 25-hydroxy-D group than in the lowest group. If you look at the components of that SPPB, the one that had the most significant difference across these groups was the standing balance score. This speaks to comments that Stephanie Studensky made yesterday about the importance of the neuromuscular junction and balance, and it looks as if D is a factor there. Two observational studies. We're looking at the baseline data here in SOF in the women on the left and in Mr. Oss on the right. Same analytical approach was used. We're looking at frailty index in relation to 25-hydroxy-D levels. What the two curves have in common here is that as D levels arise up to 20 to 30 nanograms per mil, frailty is less and less likely. They diverge on the other side of the reference range, with the women becoming more frail at higher D levels and the men going down. I am not here to try to explain that, but I think the take-home message here is that low 25D levels are associated with increased risk of frailty in men and women. Let's go to randomized controlled trials now. There have been several meta-analyses. I've selected one to make the point. Here, Stockton's analysis from 2011. He found that the starting 25-hydroxy-D level was a factor in whether you saw an improvement in performance with D supplementation compared with placebo. So for the group of trials that started at 25D levels above 25 nanomoles per liter, that would be 10 nanograms per mil. So if you're higher than that, these trials show a null effect of supplementation. There were two trials available, both by Sato, shown, the refs shown on the right. And in both cases, the starting level was less than 25 nanomoles per liter. And in those two trials, there was on average a very significant improvement with the D compared with placebo in performance. These performance meta-analyses are tricky for many reasons, including the fact that there are not standardized performance measures used in the different studies. So it would help this field a great deal to have standardization in their definitions, in their tests, and other factors. Going now to falls. Falls is really the clinically essential factor or event to try to prevent. And we know that it's complicated and no one approach is going to do it for all falls. Falls are extremely important, though, because of their implication for fractures and other injuries, loss of independence, and they are very common events. There's been one study that has looked at multiple doses of vitamin D in a randomized controlled trial and effect on falls. It is shown here. It's small, but it was carefully done. It was done in the Hebrew Rehab Center in Boston, where falls were documented, observed and documented by staff. So this is not just self-report by really elders. These are very elderly people, and thus the power in this study, because a lot of falling was going on. And you'll see that the group that showed a decreased risk of falls was the group getting 800 units a day. The other groups did not seem to benefit. Now we're going to look at a meta-analysis that takes the strategy of does D matter, and if so, does the dose of D matter? There's 11 randomized trials. Only double-blind trials, not open trials, were included in this particular meta-analysis. Heterogeneity related to dose administered in the trial was found to be high. And so the trials were separated by dose. We are looking at the effect of the low-dose trials, that is, doses of 200 to 600 units of D per day compared with placebo, and see a null effect in those 4 studies. Doses higher, in the range of 700 to 1,000 international units per day, are shown here with a pooled risk reduction of 19%. For the trials that measured 25-hydroxy-D, we plotted the risk for fracture in relation to the achieved 25-hydroxy-D levels. And you'll see that the first 3 dots, the trials that use 200 to 600 units, achieve levels in the mid to high 40s nanomoles per liter, no risk reduction. The next 3 dots achieved levels in the 60s, that is 60 to 66 nanomoles per liter on treatment, and showed risk reduction. The other 2 trials with 800 and 700 units, similar doses, achieved higher levels and were falling below that 1.0 line. So it would look to me, if you had to take a sweet spot here, you'd want to be at 60 nanomoles per liter or higher to get a risk reduction. You could ask the question, since the highest trial in that last slide was 1,000 units, maybe going higher than that would be productive. So this was examined in a study comparing 2,000 to 800 units intervention over a 1-year period with falls as the primary outcome. And the result was that there was no risk reduction in falls at 2,000 units or in any of the performance measures when compared with the control group who got 800 units. So it doesn't look like more and more is better and better here. Moreover, high annual dosing was counterproductive to both falls and fractures. By that, I'm referring to Sanders' 500,000 units once a year trial. So I think we're getting the picture here that you need to be in the 800 unit ballpark in order to count on a fall risk reduction. Now let's, what about bone? I'm not going to sing to the choir here for a long time about bone. Just we know that low D levels are associated with higher parathyroid hormone levels. It promotes bone resorption and bone loss and leads to fractures. I will go through a very recent 2-week-old publication of a meta-analysis that is interesting, I think, because it's an individual subject-level analysis as opposed to trial-level data analysis. And it involves over 30,000 individuals, age 65 and older, mean age 76, mostly women, over 1,000 hip fractures, close to 4,000 non-vert fractures. The D was calculated as your personal supplement use, because a number of the trials allow personal supplement use, such as the Women's Health Initiative, for example. The study pill dose multiplied the pill dose by how many pills were taken. Add that to personal supplements. So we're trying to get at how much D were these people actually taking. And when we looked by quartile of D intake at hip fracture risk on the left, you'll see that at the highest quartile of intake, there was a 30% lower risk of hip fracture. Now, the range of intake in that highest quartile was 792 to 2,000 international units. But importantly, the median intake was 800 units. See, just about all of them were on 800. There were a few stragglers with higher intakes. So don't interpret that you need 2,000 units here. The median intake in that quartile was right on the 800 line. So for non-vert fractures, you see drifting downward and a significant 14% risk reduction for fracture there. Now, some of the subset analyses are interesting. We've plotted the control as the dark bar on the left. The next 3 bars show the different age categories within this study. Those 65 to 74. The middle one is 75 to 84, and then the third is 85 years of age and older. And you'll see that the 85 and olders seem to have the most robust risk reduction for hip fracture with the D, although there was plenty of reduction in the other 2 groups. The next 2 bars are sorting the whole group by dwelling, whether they were community dwelling or institutionalized. And we see similar robust risk reductions in both categories. In other words, it's not the roof over your head. Third, and last two bars are calcium supplement dose that the individuals used, were taking, grouped as under 1,000 and over 1,000 milligrams per day. This is, we've had a difficulty with trial level meta-analyses figuring out the different contributions of calcium and D because, as luck would have it, those that use the higher dose Ds also often added calcium. So you can't disentangle that at the trial level, but you can get at it better at the individual analysis level. And we get the sense here that a lower calcium supplement dose may be more effective than high dose. That's interesting in view of some of the associations that high-dose calcium has been reported to have with cardiovascular risk and stones and other things. So I'd like to wrap it up and say that vitamin D appears to affect muscle directly via the vitamin D receptor and indirectly through the calcium absorption and calcium-regulating hormone system. Increasing vitamin D intake to 800 units a day lowers fracture risk on the order of 15 to 20% in elders. The mechanisms are not clearly established, but they likely involve effects on strength and balance. Increases in intake above 800 units per day do not appear to provide additional fall risk reduction. And very high, infrequent dosing is risky. An intake of 800 units per day lowers risk of fracture, estimates of maybe up to 30% for hip fracture, 15% for other fractures. It is unclear whether higher doses would further reduce fracture risk. We have no really high-dose fracture trials. So is any of this relevant to our population? Here are the vitamin D levels seen in the U.S. population. We're doing better than much of the rest of the world. And yeah, look at the proportions who are in that range of, in the green, 30 to 49. And we're talking about getting up to higher levels, 75 nanomoles with an 800 unit dose. So that would involve up to 70%, certainly, of the elderly population. So if it helps a little, it's going to help a lot of people, and so it should have a big net effect. Thank you very much.
So we do have some time for a couple of questions before we move on to the next talk. That's good.
The mechanism of action would maybe be informed by the time course of an effect on neuromuscular function. Are there any studies to indicate whether this is something that, an effect that happens rapidly, suggesting that, it shifts in perhaps intracellular calcium handling and excitation, contraction coupling and such like that, or if it takes time to develop changes in in muscle fiber? Is there any data about that issue?
Not that I'm not aware of acute effects in humans having been looked at. The ones that I know of are taking first looks out at 3 and 4 months, okay. And by then it's there. Yeah.
Okay. Thank you.
Candice Tahimik, San Francisco Veterans Affairs. That's interesting work. Actually, my question, I have 2 questions. The first question is, when you did the studies on human subjects, did you actually correlate the calcium serum levels of the individuals enrolled in that study with the response to vitamin D supplementation? A few days ago, we had the fortunate experience of inviting, in my mentor's lab, Dr. Bickley's lab, Dr. Howard Morris from Australia, and he was somehow saying that calcium and vitamin D, of course, have this correlation, and that vitamin D can have both anabolic and catabolic effects depending on the level of calcium the absorption capacity for absorption and the level in serum. So yeah, so the question is, what's your take on the correlation of serum levels of calcium?
In the big clinical studies, serum calcium is not measured accurately enough to really address that. You would need an ionized calcium, very carefully collected, and in order to see it. In small metabolic studies, you can see modest increases in ionized calcium in response to calcium supplementation, and so we know that it's changing. In fact, that's how the parathyroid hormone signal is initiated.
I see. Well, the second quick question is that in your muscle studies, you're saying that a higher dose of vitamin D is actually counterproductive to muscle performance. So can you speculate on the mechanisms involved?
Yeah, you're referring to that Sanders paper with
Yes. 500,000
units. I'm not sure. I speculated in an editorial. I don't know if you want me to repeat it, but you may be changing the metabolism of vitamin D, of the active metabolites of D with that big bolus of D.
I see.
Accelerating them and possibly rendering at the tissue level an actually diminished D state. Other speculations would include effects on bone markers, increasing bone resorption markers with acute boluses of D. That has actually been observed. I'm not sure exactly how that happens, but yeah, I think it's going to be hard to get a better understanding of it because I don't know who's going to be able to do the experiment.
Thank you.
Marco Brotto, UMKC, and of course, the following up on the excitation contraction coupling is very interesting because it's kind of old data, but a group, a skeletal muscle group, Vaca et al., they showed many years ago that actually if you activate VDR in skeletal muscle, you actually bring a lot of calcium inside muscle cells. And through a mechanism that we've been studying, and we actually think it's involved with sarcopenia, which is called the store-operated calcium entry, which replenishes the sarcoplasmic reticulum of calcium, making more calcium available now for the next contraction. And so perhaps something to think in terms of a more cellular mechanism, and perhaps the higher dose, now you could have the calcium paradox, where too much calcium now could be damaging that process itself. So.
Thank you. That's an interesting comment. I agree. Okay.